welcome to the Adapted Tai Chi Exercises webinar. And I'm Rosalind. And today I'm excited because it's Mental Health Awareness, Mental Health Awareness Week. And I have the pleasure of introducing Kasia Sikora shortly to do a talk for us about how she's introduced Tai Chi exercises into the service. And I just was briefly say about myself, I've been teaching the Tai Chi exercises courses since 2008. And I was saying to Kasia before we started that I thought most of my courses probably were to palliative care, hospices, and also falls prevention. But I've just been looking back at my notes and I've taught rather large number. It's been really popular in mental health, so I'm very pleased to have a talk here. I've taught in Avon and Wiltshire, Cambridgeshire, Norfolk and Suffolk, Sussex. It really is great to have Kasia with us. So I'll pass her over.
Ross has asked me to give you a little talk about how we as a service implemented Tai Chi into our practice. So my name is Kasia Sikora and I'm an occupational therapist working with adult and older adults inpatient mental health service at Berrywood Hospital in Northampton. So I'll be sharing, like I said, my experience of implementing the adapted Tai Chi exercises within our service, which is a combined occupational therapy and a physiotherapy team. I'd like to talk to you about the benefits of adapted Tai Chi exercises for people experiencing mental health difficulties. And I will briefly speak about the model of practice that we use here at Berrywood, which is a model of creative ability. And I will explain how Tai Chi fitted into our overall treatment program. I'll also touch briefly on some of the practical challenges that we face when delivering adapted Tai Chi sessions on our busy wards. But also I want to tell you about some positive experiences where Tai Chi sessions significantly supported patients' recovery. First of all, a little bit of context. About our service and our patient group. So Berrywood is an NHS hospital with 5 adult wards and 2 older adult wards. So across, that's 77 beds. We have a PQ ward for males. We also have a recovery men's ward at 17 beds and female equivalent of that, so another 17 beds for ladies. I currently work on rotation on a mixed ward, which is a 12-bedded ward where a lot of our transgender population comes these days. And we have a functional older adult ward with patients experiencing mental health problems and a dementia ward. Outside of that, we also have 2 CAMS units and a couple of other wards, including a forensic and a long-term rehab setting. But when we were first incorporating the Tai Chi into practice, we only done it within the boundaries of our service, so the first 7 wards that I've mentioned. So that's what I'm going to be talking about today. So I work predominantly with adult population, but across adult and older adult side, all the patients who are admitted are in the acute state of their illness. Most commonly we meet patients who have a bipolar affective disorder or schizophrenia, schizoaffective disorder or psychosis, including drug-induced psychosis, personality disorder, post-traumatic stress disorder, or severe anxiety and depression. Some of our patients have dual diagnosis, so as well as having a mental illness, they also sometimes have conditions like OCD, autism, and ADHD. And most of our patients experience severe or repeated trauma, so they have likely developed maladaptive coping strategies to manage life. As you can imagine, all of the admitted patients are in the mental health crisis, and they often experience significant distress and significantly reduced level of functioning. They are at times disorientated, detached from reality, agitated, or with low mood and emotional dysregulation. So they are often experiencing cognitive difficulties as well as reduced motivation. And obviously, some of our patients also struggle with reduced physical ability, particularly within our older adult population. Many of our patients on both sides have coexisting physical health conditions, such as COPD or Parkinson's or hypermobility or severe back problems, which then limits their ability to engage in more sort of active or higher intensity interventions, such as gym, that we also have on site and we manage for some of our patients. So how our journey with Tai Chi began is that just over 10 years ago, as a service, we were looking to build on our existing skill base to improve mobility and function for our population. And that's when we found process training. So my manager thought it was a good match for us because there's evidence that movement such as Tai Chi is beneficial for patients with mental health conditions. So just to give you a few examples, depression, where adapted Tai Chi is beneficial because it's gentle and non-demanding and structured, but not overwhelming. And it's focused on small, achievable movements with a slow pace and repetition, support patients' engagement without pressure when the emphasis is on movement and the breath, which can help patients reconnect with their bodies when they may, otherwise feel withdrawn or disconnected. With psychosis, for example, Tai Chi offers grounded and predictable activity with slow and rhythmic movement that helps to anchor attention in the body. So the focus on bodily sensation and breath can support sensory grounding, and we do a lot of our Tai Chi, adapted Tai Chi sessions for that purpose, and to reduce arousal and to provide a sense of safety and containment, because it's particularly important in inpatient settings where our patients are particularly out of control. So for our population with personality disorders, the population that can experience emotional intensity and dysregulation and interpersonal sensitivities, I guess, which just means that their bucket fills up a lot quicker than perhaps a regular person. So they get easily overwhelmed and have difficulties with trusting group environments. Adapted Tai Chi supports this by offering choice and autonomy within sessions and a non-judgmental, sort of non-verbal form of engagement, and the opportunities for self-regulation rather than the external control, and a coping skill that can be utilized after discharge. So we often signpost to local Tai Chi groups, and we know that some of our ex-patients attending those. So the absence of performance pressure and the emphasis on personal experience can feel safer than sort of more verbally demanding therapies, which is why Tai Chi is, I think, particularly popular on our female ward. So for patients with bipolar disorder, individuals with this condition often experience significant fluctuations in their energy levels and mood. So Tai Chi can be adapted to provide a calming and regular activity during periods of sort of high arousal in the manic phase, where they're feeling particularly agitated, but also offers a gentle activation during the low mood states. Because Tai Chi is flexible in pace and intensity, it can be safely adjusted to that sort of mood cycle for patients. And lastly, ADHD. So adults with ADHD may experience restlessness or difficulty with sustaining attention and impulsivity. And although Tai Chi is slow, it can be very effective for this group when adapted appropriately. So the continuous flow of movement and clear demonstration, as well as repetition, helps to channel energy in a structured way. And over time, this supports attention regulation and body awareness and impulse control. And I have a really nice example towards the end of my talk where a patient who had ADHD, and we really successfully used adapted Tai Chi to almost every time before we needed to have a conversation with that person or delivering further treatment, because it was just so regulating for that person. So I also want to quickly mention the model of practice that we use, and only just to sort of illustrate where the adapted Tai Chi fitted in and where was its place within our service. So we use Vonner du Toit model of creative ability, it's VDTMOCA, which is a South African framework, and some of you might be familiar with that. So it's a tool that we use to assess patients' level of functioning, which is called creative ability level. And we also use it as an outcome measure to determine change in function through something that we call task assessment. So this framework is based on human development, and basically we believe that the intrinsic motivation that triggers somebody to do something can be interrupted during the episodes of mental illness. So in normal development, so basically we see 3 stages more than we see other stages of creative ability in the hospital. So I think altogether is 10. We see a self-differentiation level, which corresponds to normal human development from sort of 6 months. So from the moment that a person sits up to the toddler stage, 2 years old. And then the self-presentation level, which is between 2 and 9 years old. It's quite a big gap. If you think about a child that is 2 years old and a child that's 9 years old, it's a big difference. But the common theme within this phase is the question that the person may ask to understand the world around them. So the question will be why and how. And these questions are asked to enable this group of people to the exploration. So the interest of this group is more on the process rather than the end product. So in groups, we would see that this population, and I'm deviating from Tai Chi now, but let's say they would be making a cupcake. The cupcake would be very overproduced or unfinished. They would either put sprinkles and then a cherry on top and then a little bit more cream, and it would just never end. And Tai Chi works really well with this population. And the last one that I'm going to mention is passive participation, that in regular development is between sort of 9 years old to about 13 years old, and it's all about norm compliance. So people at this stage, they sort of understand the world around them, and they understand how it works. They have the basic concepts, but they feel quite fragile and perhaps unsure whether they will fit in and whether they will perform to the level that's expected from them. So they want to get everything right, and they want to use the right tools, and they want to achieve a good quality end product. So the sort of questions they will be asking would be, what am I supposed to do now? Or is this right, what I'm doing? And they ask those questions to improve the quality and efficiency. And we devise our treatment sessions, in accordance to levels of creative ability, just to suit each level of functioning. So we carefully plan our treatment to enable patients to progress through the stages of creative ability until we are confident that they have achieved their baseline of functioning, or they've achieved their new baseline, of functioning, or they discharged. So we discovered that Tai Chi fitted on beautifully with the aims of all of the developmental stages, from that sort of incidentally constructive to the passive participation level and beyond, which meant that when we were devising our weekly timetables, we didn't have to categorize this adapted Tai Chi group as belonging to a self-presentation level or another level, but we could have patients from all different levels of creative ability attending that group, and that was really lovely, and it still is. So how did we do it? We first of all completed 2-day training with Ross, and following that we got together and familiarized ourselves with all the available resources that we were provided with. We also had a lot of discussions within the team, as some of us were more anxious than others about running a Tai Chi session. So I was newly qualified and pregnant at that point and petrified about doing the Tai Chi group, even with Ross's really helpful sheet of different Tai Chi poses. I just found it really daunting. But luckily, some of our team members had seen Tai Chi in practice, before, or were a little bit braver and bolder and, eager to try out. So initially, we opted not to introduce Tai Chi as a ward-based session, but it became a department group where not only we were able to watch and sort of support each other and give each other feedback, but also to set standards, for ourselves and our patients. And we have a really nice big open space, a physio gym with a nice enclosed garden where our groups began. Depending on the weather, they would either take place in the garden, or if not, in the physio gym. Those garden sessions were a lot more popular, I have to say. So we offered, I think, approximately 12 spaces based on the size of the room and the amount of facilitators, but we accepted anything between sort of 2 to 12 patients at one time, dependent on interest and sort of patients' individual treatment needs. But the sessions would run 2-3 times a week at that point. So I've mentioned we had 2 facilitators, sometimes 3, and each time a different mix of staff, with a few sort of key members of staff who got the gist of it a bit quicker than others. And those were the people who initially led the routine, whilst the less confident staff, like myself, were leading the pre and post discussions with patients, including, psychoeducation. So if you're running in your service anything like anxiety management sessions or mindfulness or coping strategies group, or falls prevention, strength and balance, anything like that, then Tai Chi is going to be really helpful. It can be incorporated into that. So the introduction part, in my introduction part, I was aiming to sort of develop basic concept and awareness of Tai Chi for my patients. So and we're talking a sort of like higher self presentation, mid to higher self-presentation, and passive participation patients, because those were the patients that were initially coming off the wards and able to engage in those sessions. So we're not talking about those lower levels of creative ability where perhaps too much language is not helpful. But in my introduction, there were key components such as, explaining what Tai Chi was, and then explaining what Tai Chi was not, and why it was helpful, why it could be beneficial for us. And we were setting some ground rules, such as letting patients know to work with their own limitations, not to carry on the Tai Chi pose if in pain. And we also explained that we were not Tai Chi practitioners, but we received our training from a Tai Chi practitioner, and therefore what we offered was a variation of Tai Chi, possibly, but not a Tai Chi in its sort of pure form. And that was just to sort of get the expectations right. But we obviously were trying really hard to get as best as we could. So we also had chairs available for patients to sit down, as we found that this was needed for less able and sort of more physically impaired patients. And if that happened, then one of the staff members, one of the facilitators of the group, would sit down and model the exercises in the seated position, whilst the other would be standing up. Our sessions consisted of sort of very simple warm-up exercises. I like to start from my feet upwards, so be, just the basic wiggle your toes, rotate your ankles, and then jog on the spot for a little bit, either seated or standing up, and so on. So that would be the first part. Then we would progress into like Tai Chi poses, and then we would have a flow, so like 3 moves combined. And then we would sort of have a bit of a cool down, which was the gathering of the chi. And then altogether, it was approximately 30 minutes, plus the discussion initially and after session. It was overall about 45 minutes per session. Sorry, we also used speakers to play Tai Chi music or relaxation music, etc. And that's it. So over the course of a few weeks, we all started to follow the same or pretty much very similar Tai Chi routine. And then we thought that we can finally open the Tai Chi sessions to wards and not just the department, and as we were confident that we could lead the groups independently. So some of my favorite Tai Chi moves that I use is the spring summer, which is when I raise my arms, and the way I would do it, it would probably be one of the first ones that I use when I'm leading a group. So the first one, I would be just basically making up a little story to that it's like a tree that just sort of grows and develops over spring and summer months, and then sort of in the autumn the leaves would fall down and the tree would not be active for another few months. And then I would shut up and I would just let people enjoy the movement. And then maybe after 2 or 3 moves, I would say, and now breathe in and breathe out, and breathe in and breathe out. And then I would be quiet again until we would do maybe perhaps 10 repetitions or so. And then I would try to move to the next pose in sort of swiftly manner. So if I'm doing the spring summer pose, the next one would be maybe picking the cherry when I cross the midline, and I'll talk again to patients about the pose, and then I'll stop talking, and then I will tell them about the breath. Because of the VDTMOCA and the levels of creative ability, now if I'm running a sort of predominantly self-presentation group, I want to enable explorations. I want to work with the principles of the self-presentation level. So I'll be saying things like, which pose shall I do next? Or, does anybody know a different pose? And sometimes we would end up doing, crazy things like a wavy tree, which doesn't exist outside of Berrywood, or anything that sort of patients want to try. and is safe. Or I'll do a bit more visual things like the ball, when I'll be just sort of be breathing in and out with the ball, or getting the ball really heavy and passing it to each other, and just would just be really creative with it. But in my passive participation groups, if I have predominantly just sort of patients at those levels of creative ability, I want to get it right for them. I want to focus more on the quality of the movement and on the breathing within those sessions to just sort of enable that concept formation, and and that's how it would be done. So I have a couple of examples for you of two patients for whom I found Tai Chi being particularly helpful. The first example is the chap that I had on my ward a few months ago. So it's a man with a history of trauma and self-harm, personality disorder, and a very prominent ADHD. So he was assessed by me at sort of self-presentation level, patient-directed phase of creative ability, sort of motivation, the level of a sort of 6-7-year-old. And this patient was unable to, I'm sorry, I'm going to have to take a drink. So he was unable to complete any conversations with me or with the members of the MDT, and he was perceived to be difficult to engage, but you could sort of tell that he really wanted to, but he would often get very impatient with people or just upset at them, and he would just walk away. So that particular morning, I had a conversation with him, very quick conversation with him about something that he was eating. We're from the same part of the world, so it was just a quick conversation on Polish breakfast. And after that, I was running a group, so I've invited him to come and have a look. And I don't set expectations. I just said, if you want, you can come in and have a look. And if you like it, you can stay. If you don't like it, you don't need to stay. But because he's at that self-presentation level and he was curious and he wanted to see and he wanted to explore, he came into the group, and he's very movement seeking. He was a very movement seeking man, so he naturally wanted to copy my movement, and actually did really well. I was amazed how well he's engaged. I think that session was about 25 minutes. The sessions on wards are often shorter than department sessions. And following that session, he was able to sit down with me for the first time properly, explaining the reasons for his, admission to the hospital. And then we were able to devise a plan of action for him and set his admission goals. And it kind of gets me a little bit even thinking about it now, but he said to me, and I will always remember it, that he said, I don't remember when was the last time I was this calm and focused. And I firmly believe that this was because of the Tai Chi that we did beforehand. So when he was on the ward, I'd probably do Tai Chi routine with patients about 4 times a week. Normally I do it once, maybe 2 times a week, but I'll do it more often because of how beneficial it was for him. And it really did help us to engage with him about other things as well as a result of that. So the second patient I want to mention is a lady who I was involved with about 3-4 years ago. She's a female in her late 40s with unspecified psychosis, characterized by, her like delusional and paranoid thinking, and a need for organizing her environment. If I'd let her in the room, the pens would be out and she'd just be sorting them out. So she's normally quite an active lady and a keen cyclist. and she's been assessed by me at passive participation level, therapies directed phase of creative ability, so about 10 years old. Obviously not 11 or 10-year-old function, but sort of in her level of intrinsic motivation. So for her, she had an instant interest in the adapted Tai Chi sessions and attended ward-based groups of her own volition. And she was able to follow the movement with no difficulties and was able to focus throughout. And it was really noticeable how receptive she was. And she was really absorbing the atmosphere of the session, and always reported the sense of peace and relaxation that she experienced in sessions. So she's asked me for some extra resources, which I have shared with her, and she continued practicing Tai Chi in her room every day, and on some occasions with another patient. When she was ready for discharge, she reported that it was Tai Chi that really helped her reconnect to her body. And through our social prescribing service, she's found a local Tai Chi group that she's signed in to do. And I'm hoping she's still doing it now she's not in hospital. We are no longer, very sadly, offering Tai Chi as a department session. This is because, probably as everyone else, we're just sort of facing, financial pressures, and we've got less staff that we used to have, and we're having to do more. Current department sessions that we offer are very discharge focused. So all of the sessions like Tai Chi are falling onto our ward timetable. So because of that, we sort of lost our lovely space where we can, shut ourselves away from everybody and just carry on with movement and enjoy the session. Because obviously wards are very busy and demanding environments, we do get a lot of interruptions. So some of the barriers of facilitating Tai Chi sessions today, for me, are, poorly set up environments with noise and limited space and constant interruptions from ward routines, from patients being called for medication, and meetings with a doctor or a visitor. And it doesn't matter if I put a sign on the door, it doesn't matter if I try and put some obstacle in the way, somebody will always find a way to come into the room. Obviously, patients are also moving in and out of sessions due to their sort of fluctuating concentration and capacity. But these realities, they just require flexibility and acceptance. And rather than striving for a perfect session, today I focus on maintaining a calm and therapeutic tone and supporting engagement, in those sessions as it unfolds. So this is my journey of implementing Tai Chi. Thank you very much for listening. Please do let me know if you've got any questions, and I'll try and answer them as best I can.
I have a question.
Yeah.
I thought everything was going so smoothly. It was so brilliant. It was really good. And I was thinking it doesn't seem to be the same with where I work. And it wasn't till your end point where you're saying that there's disruptions, there's interruptions, there's medication and all the rest of it. And I thought that's exactly the same as where I work. Exactly the same. Whereas a place I did have where we were able to do it was perfect. And then change of ward has changed the way the dynamics of the group are run, and you just have to work with it really, and sort of do maintain your calm and that calm presence and support. But it was really interesting to hear all of this. So
thank you very much. Yeah, we, like I said, when we had our the space still exists. It's just now cluttered with forever piling higher and higher to sort of physical health equipment because we're running out of storage and it has to go somewhere, and and we can't really use that space as effectively as we did before. And problems, with maintaining just of that environment is really difficult.
Yeah. Thank you.
Thanks. Thank you.
Elsha had a question next. I was going to thank you. We jumped in there. That's fine. That was really very interesting because I've learned a lot. I didn't realize that people had it. As show a lot of ignorance here. I know about physical developmental stages, but I hadn't realized about the mental. The creative ability. And just like Barbara, it's so sad that you've lost your space. I keep reading it in our Frontline Physiotherapy magazine, the physios saying, they're losing the space to do things. But it was very fascinating and lovely case studies. And I got all choked up too. But
we have lost the space in that respect, but because we moved Tai Chi to our ward spaces, the patients who initially were excluded effectively from attending. So our most poorest patients, so patients on the PQ ward and on our dementia ward.
What's PQ?
PQ, it's the intensive care for mental health. So it's a small unit full of very unwell men who are just buzzing all day. And equally our dementia unit, with a lot of disorientated people, those two groups, they really do gravitate towards movement, and Tai Chi is so successful on those units that, we would have always opened the wards to having Tai Chi, and really the sessions were initially locked for our benefit. Just so we can consolidate our knowledge post-training. But it's not all bad because these people now, can also enjoy Tai Chi.
Okay, we've got that one in the chat here. That's Elsha. I don't know. Elsha, do you want to go first, and then we'll do because I think you put your hand up.
Yes, I didn't know if I must have raised it and lowered it again. If you, other than the space, if you had to restart planning your class again, would you do anything differently?
I would probably pay more attention in the training. At some point I would have loved to revisit the training, because the thing I got set in the few poses that I feel comfortable with, and although I do sort of experiment, is patient-led. And I would also like to find a way to incorporate those poorest patients a bit sooner to the training, because like I said, I feel they really benefit from it.
And then Nina has said, great presentation, so inspiring to hear about how much patients have been helped by the classes run by you and your team. That's great.
Thank you very much.
Yeah, Colin's going to go now. That's Nina. Off you go, Colin.
Thank you, Kasia. I really enjoyed the presentation. At the start, you mentioned your model. You mentioned a South African tool or something, and I didn't scribble it down. Could you tell me what that is?
It's MOCA, MOCA. It's Model of Creative Ability by Vona Dutoy, which is why it's often spelled as VDTMOCA, because it's Vona Dutoy Model of Creative Ability.
Okay, thank you. I'll check that out. But the thing I put in big letters was the need for a space, an appropriate environment in which to practice, because that's basically what's missing from our place, is a collective space where people can't walk past and feel the need to fill silence with words, comments about what you're doing and Bruce Lee noises and things like this, and you think people can't read a room.
Do you have any communals in any sort of communal outdoor space?
It's very small. It's very small. If we got 4 people in there, it would be a bit of a squash. But you know,
Okay.
it's still it's when it's like the continuity we have because we've got 2 step down acute wards, and so the turnover can be quite brisk. So one week you might have some people on the ward who whip everyone up into a social frenzy, and all of a sudden you've got 8
Mhm.
ladies out in the ward garden, and it's wonderful. You can connect them to cues from the environment, the breeze on your face, the sound of the robins in the trees. It's wonderful. And then 3 or 4 key personalities get discharged or move on, and then all of a sudden it
Yeah,
all crashes down. So you turn up the following
yeah.
week, and it's like you're starting at square one again.
That's a
So
very familiar dynamic, Colin. Same for us. But to just sort of make a comment to the first part of what you said, you can do Tai Chi with 1 or 2 patients as well, and it works just as well as long as they sort of, so you can connect them together. And I found that when you do these exercises together, if you're able to achieve a little harmony, you know, which I try to do with the flow in particular, putting 3 poses together, it does that. It just really consolidate people together. So you don't need a big group. You might be able to get a real success with just 1 or 2 people as well. But I do feel your pain because I share it
just
as well.
a comment on that, because if the Tai Chi is on the timetable for the ward and no one's engaging, I still go out into the ward, into the garden, and I do it myself. I'm
Yeah,
the only person there because you never know who's looking out of their window.
yeah, and
And
that role modeling is so important,
yeah,
isn't it? Mm.
yeah. Thank you. Thank you.
Thank you.
Wonderful. Have we
Okay.
anybody else anything? It's fun to share experiences that they've had in mental health. Because that's what I wanted to do. I thought, you know, there must be so many people out there like Colin and yourself and Barbara and doing this and like just connecting with other people and finding they're struggling with the same things or what goes well. Or I was going to ask when, like, in terms of funding and keeping this going and that, and what sort of outcomes the physios usually go on about outcomes. Do you are you able to show that with this the South African
VDTMOCA.
yeah.
Yeah, so following most sessions, it's more true for assessments, but not only. If we want to really track somebody's recovery in particular, we will do something called creative abilities scoring form, which is directly linked with MOCA model, and we track at what level that person is for each particular demeanor. So it could be, you know, how did they use their tools? In this example, it would be how did they use their body, because their body in this session was their tool. What was their end product like? So how did they manage to achieve the session? What were the social norms like? What was their level of motivation, intrinsic motivation, what they were triggered by, what was their anxiety like, and we track those. It's, you know, to some extent subjective, but if you know your patients well, you can provide that track of patients' recovery within those sessions. But it's never just for Tai Chi, because there's also medication, there's also other therapies, there's also psychology and physio, and so it's not just us, but yeah, that's what we have.
Yeah, and so obviously, because you said you tend to do that, you really enjoy it, so it must be beneficial. Like
I love it, and you know, I like it the most when I get staff, because on some occasions, and it's particularly true for PQ, I do get a lot of support from staff. They come out and they do exercises with me in the communal area, and then patients come and they do it as well. And you can see the staff really need it as well. They want to be together and they want to do this.
That's interesting, isn't it? I was going to ask, is it just the OTs who do the classes? When you said you had 2 or 3 people facilitating?
So yeah, those are occupational therapists. So the numbers of our OTs have decreased, but we still tend to have one therapist on every ward and sort of half therapy assistants. And we've got currently 1 physiotherapist and 2 apprentices, but they just have come to the end of their journey and they'll be leaving. I think they use strength and balance more than they use Tai Chi, but this is probably more to do with their lack of confidence, because they happily do Tai Chi in a session with me on the ward. But when they, but it will come, you know.
Yeah. And the people in the community, do you know what sort of, is it achievable? Is it, you know, when you say Tai Chi, sometimes people are doing a form or they're using sticks and swords and things. Do you check out the people?
What do you mean, for like physical health equipment on this sort of thing?
No, I mean the people, when you refer people into the community, do you know?
So I don't
people?
personally refer people because I don't know. I have not checked those groups myself. There is a social prescriber within the hospital. They are finding out the information from the patient, and they are linking in with different services. But there is a middleman, and I don't get involved in that.
Yeah, I was a bit anxious because you know you don't.
Yeah.
Enjoy what you're doing, which is the more qigong. I know we call it Tai Chi, or the individual movements.
Yeah.
And it has the principles of Tai Chi, but I was sort of thinking, oh gosh, if they go out and, you know.
Yeah, and I'm sure that some people in community, they also have an agenda, and I would not want to get it wrong for the patient. So if they enjoy something and want to carry on with it, because we don't offer the service for ex-patients, there is a separate service that can link patients in with sort of similar groups in the community.
I know. Do they do yoga as well? And people doing yoga, or it's mostly Tai Chi?
We have an external person that comes to do yoga every Tuesday, but it's nothing to do with occupational therapy service. There has been 1 or 2 people in the past that have been sent to do yoga training, but it somehow never embedded itself as well as Tai Chi. And I think because of how we in the beginning have worked as a team to get it right for ourselves as practitioners, that has made it a success. And I don't think it was the same with yoga. I do know some very basic yoga moves, but I'm usually not brave enough just to share it with patients.
I think an advantage is you're sitting or standing, aren't you, in the Tai Chi? Yeah. Right. Is there anybody else anything else they want to add? I'll give you now or never. Oh, Colin, yeah. You go ahead.
Sorry, I was just my notes were very hurriedly scribbled, and I've just deciphered what I'd written. I liked your comment, Kasia, about developing a narrative to describe the flow of the movements and things. And I realized that that's something I'd overlooked, because another comment you made is about the importance of reconnecting with the body. And I realized it was that more somatic angle. And I realized as essentially, I'm a gym instructor as well, and I practice a martial art. So I was more about those bodily sensations. So you're opening the chest, you're mobilizing the shoulder girdle, which I think some people relate to. But I think that development of that narrative, they could work so well together. I think so.
And
I
this is
think that's something I'm
particularly
going to look into.
It's fantastic that you've made that comment. It's particularly true for patients who perhaps have learning difficulties or like a few diagnoses together. They need the extra I mean, as long as they're not acutely psychotic, I think the language, and or not overwhelmed, the language can be very beneficial alongside with movement. Yeah.
It's
Awesome. Thank you.
No, sorry, did you have another? Okay. When I first did the Linda Chase Broder had a course before I even started doing, when I was sort of interested. I was a nervous wreck at the beginning too. And I went on her courses at Tai Chi and Qigong Forum for Health. And she was one of the first people to bring Tai Chi into the National Health. And she used to go in a residential home, and she actually was a poet, and she would use poetry, and she would come out with a line just like you're saying, the sun comes out in the morning, and then the next person had to make up a line for the poem, like the water goes down. And
wow.
Yeah, and they put them all together as a movement.
That's really great. Well, I often do things like if we're picking the cherries, so I will stretch over and I say, I'm picking the cherry because cherries are my favorite fruit. And they'll be like, and Colin, what's your favorite fruit? And be like, mango. Okay, well, you picking let's pick mangoes now. And then that kind of makes it a bit more lighthearted as well. And
interactive.
Yeah.
And I can share that as well. I had one of the Tai Chi instructors use the whole Shibashi form as a sequence, as a story. I'm not sure if she, maybe just with her ordinary clients, just made it a story, which made it easier for people to learn.
Absolutely.
Yeah. Well, maybe put that on my website. Right. That's been really very, very good, very interesting, fascinating, lovely sharing things. So I will say my next huge thank you for Kasia, before I forget. And I got your name right that time. Thank you, Kasia. And next month on the 2nd of June, a wonderful Tai Chi instructor, Luke Shepherd, is going to give a free session. Some of this, they say there are no secrets in Tai Chi, just things too small to see. And he will be sharing some of these small things with us. And following that, in July, I have Madja, who's an audiologist who's been using a very adapted Tai Chi with her vestibular patients as a form of vestibular rehabilitation. Do check out my YouTube channel, as always, and my website. I'll be putting the recording up in a day or two. I checked to see if I didn't need to edit anything out. And check for future webinars. I welcome any suggestions. If anyone wants to do any webinars for me, that would be wonderful. And thank you all. Thank you, everybody.